Hi everyone, a warm welcome to today's CCI webinar, which is a very hatke webinar. CCI, of course, is known to be doing fantastic webinar, which are hatke very often, but this one is really a hatke webinar because the thing is that we always know how to diagnose TB, how to treat TB, how to prevent TB, but that is not enough for our patients because they have so many questions to ask us and we actually really don't know the answers, and therefore every person ends up giving a different answer. So if the patient will ask the same question to five different doctors, all the five different doctors are going to give different answers to these very important questions, which actually prevent infection, prevent reactivation, and actually dramatically change patients outcome to our treatment. So today we're going to be talking about those very important things which we don't end up regularly reading, but they actually make up a very important part of our practice. And I'm so very happy that we have this fantastic panel. I mean, each of our panelists is absolutely a brilliant panelist. They all are TB authorities, and in addition to great knowledge, they have vast experience, which is actually going to benefit, improve our knowledge. I'm just so happy that we had this discussion in CCI Ultra on this topic, and our Dr. Krishna was like smart enough to immediately grab it up. And then our webinar team, Dr. Chenam Chetty, Dr. Atri, and Dr. Shivani has pushed it forward. And I'm just so happy that here we are discussing something very important, which is going to be about what advice to give patients if they have treatment, or what advice to give them if they want to prevent TB, or what to do to create awareness, what is the government doing for awareness, etc. So this is basically a lot of introduction I've given. I think I'll just start our webinar first. Is Dr. Animesh here? I can't see him.
He would be joining. He had some trouble with the link. He would join.
Okay, sure, fine. So then, Radha, can I start with you?
Yes, yes.
Radha, our captain, our champion. Let me start. I'm not. I think. I don't think Dr. Radha needs any introduction. As I come with questions, I'm going to introduce people. But Dr. Radha Munje requires just no introduction. She is a brilliant pulmonologist. She is a wonderful lady. She's an extremely active member of our CCI. And most importantly, she is my bestest friend. So, with this brief introduction, Radha, let me ask you this question. So, basically, we have that there are so many people who are poor and they have to migrate. So, how do the migration patterns and urbanization impact the spread of TB? And what social measures can be taken to address this problem?
Yes. First of all, thank you for that lovely introduction. And thank you, CCI, for this really hatke webinar where we are really going to talk about our patients' welfare. It's not only about the treatment and the guidelines or the newest things which we always discuss. So, and thank you, Amita, for leading this forward. As you said, we know that poor people suffer most from TB, not only from the infection and disease, but everything that comes with TB, the catastrophic cost of diagnosis and so many difficulties they have. But when we talk about this migrating population, we have to understand that this is a group of people or, who go from one place to another in search of their own livelihood most of the time. So, like if we talk about, I'm sure it is there everywhere in our country, but we quote examples about which we know. So, when we talk about Maharashtra, there are laborers who go from one place to another where whenever the जो फसल निकलती है, like
Yes,
राइस निकला है, चावल
yes,
काटने वाले, एंड देन ऊस तोड़नी कामगार जो हम लोग बोलते हैं, दे गो आउट फॉर कटिंग दिस शुगर केन्स व्हेन द हार्वेस्टिंग इज देयर. So they move from one place to another. So this poses different issues with them. One is uh, the nutrition and the good living conditions. They don't have that. One. So they are more susceptible to these infections. Secondly, once they have these symptoms, they may not be near to any health, like wellness center or even a PHC. they may not be near and it may not be possible for them to visit. So the diagnosis gets delayed. That is the second thing. Then the third thing is no sooner are they put on treatment, and if their work is over and they go to another place, then these people are likely not to take treatment because they don't come on treatment immediately. It takes a longer time, and they have to take an initiative for that to approach a health center or a government, whichever clinic is there, to approach and get the treatment. And these are the people who are then listed as lost to follow. So if they are diagnosed at one place, so if we quote an example like somebody has been working in Gujarat and now they migrate to the borders of Maharashtra. And if they are not notified or have not been told what is to be done immediately, then they are recorded as lost to follow up. क्योंकि वो तो मिलेंगे नहीं. Even if a health visitor makes a visit, it's not possible to, meet them and ensure that they are taking treatment. So this is one part of it in which way they suffer. Second, the food pattern. So they are naturally, more susceptible to having disease. And you also added a question on urbanization, Amita. If my time is not over, shall I add one line?
Yeah, just in a quick line. Yes, yes.
Yes. We all are aware about what we are facing with urbanization, not only pollution, but a changed lifestyle, late nights, not having good sleep. Even if we have loads of food, the quality of food which we eat or prefer to eat may not be good, and hence the immunity suffers, making us more susceptible. And most importantly, in the urban cities, the travel, which exposes you to loads of infection. That's it.
Great, wonderful. And what social measures can be taken to address mainly the migration patterns?
Yes. So for this, the most important thing, see, they have to go out for their livelihood. So we can't ask them to wait at a place for 6 months. So whether the treating doctor, whether he is in government or a private practitioner, whatever, the most important thing is once you know that they are not a stable population, you have to let them know what is the duration of treatment and how treatment is available anywhere and everywhere. If
Excellent.
they prefer to buy, then you can write on the card and explain that you have to go to the pharmacy and keep on taking your medicines. And if they don't want to go and buy, naturally, most of them would not, then you have to link them to the governmental agency and tell them that whenever you are moving out, do take a transfer check. And as soon as you reach another place, go to the nearest health center, give that
Great.
transfer check, and continue with the treatment. That's it.
Wonderful, wonderful. So very well answered. We never really think about migration population, but they suffer so much. And it would be very, very important that we make the journey of transfer of treatment from one doctor to another very, very smooth, and we really explain them everything. So great. Thank you, Radha. Thank you so much. Hi, Dr. Animesh. Welcome. We missed you in the beginning. I believe you got little stuck. So we'd like to come to you
Yeah,
now, the second question. So again, Dr. Animesh requires absolutely no introduction. He's a very, very active CCI member of ours, an excellent pulmonologist and infectious disease specialist from Mangalore. And TB is his passion. So I want to basically ask you, Dr. Animesh, that how does poverty and poor living conditions contribute to transmission of TB? And how do you think what steps could be taken to reduce this?
thank you for that question, Dr. Amita, and thank you for having me here to CCI as well as the organizers. See, the thing is, TB is very much a social disease. We all know that, and I'm sure that there's no denying the fact. Having said that, TB, because of its own nature, and then the transmission by the respiratory route, it actually gets complicated further and it gets propagated further because of these poor living conditions. Now, in poor living conditions, and again, if there is overcrowding present, and if there is, say, if we say that there is no ventilation or poor ventilation, there are damp conditions, so all these aid in the transmission of TB. And poor socioeconomic status also contributes to people having lower nutritional status. So that further aggravates because there is low immunity. So with all that put together, this becomes a more of a problem. And then if there are close contacts there, again, if there is coughing, there is improper disposal of sputum, children being there, young infants being there, all those also complicate the problem. So this again becomes a big problem. And how do we go about mitigating, or how do we reduce it? So it's not easy. We have to look at multiple ways, but we cannot say that the poor will suddenly change their status and become rich or become middle class. It's not going to happen. But what can happen is we will need to target them and educate them. We will have to see to it that they understand that this is how the transmission happens, and to protect their near and dear ones and the people in the vicinity, they need to take some measures, and they have to follow some cough etiquette, and that is something which we need to do. So they need to be understanding that. And as we all know that very soon after starting the treatment, they become non-infective. So we have to make sure that they take treatment early. At the same time, when they are coughing, they make sure that they are not going to do that just openly, and so they have to cover their disposal of sputum has to be taken care of. So these are some of the things that can be done, because we cannot change overnight their status. At the same time, now we have a very good Poshan Yojana where they can get some nutritional supplementation and nutritional from the government itself, from the program. So I think that is also something which can help them. So these are some of the things that can be thought of.
Very well said, Dr. Animesh. So basically, people who are in poor living conditions, first of all, their nutrition is poor. Often they don't have good ventilation, and therefore infection is going to keep on transferring. They are really living in crowded conditions, so one can affect the other one much more. And lack of sunlight, lack of vitamin D, this is what is the problem. And as Dr. Animesh rightly said, best is educate them for the symptoms. Early diagnosis and effective treatment with better nutrition would be the best. Thank you so much, Dr. Animesh, for this perfect answer. Now I'd like to come to Dr. Anil Maske. So Dr. Anil Maske again requires no introduction. He is our most committed soldier of CCI. And I would not just call him the soldier, I would call him the commander of CCI. Our fellow member from Maharashtra, we are just so proud of. Extremely sincere, extremely hardworking, but extremely modest and humble. Never talks about all the work that he does. So welcome, Dr. Anil Maske, to you.
Thank you. Thank you, ma'am. Thank you, ma'am.
Yes. I'd like to ask you this question that, basically Dr. Animesh very nicely spoke about educating. So basically, I want to ask you that how can education campaigns and digital platforms be designed to bring about awareness, not only for poor people, but for everybody? And in what way can you bring about awareness in TB prevention?
Yes, ma'am. As we are targeting to 2025 to eliminate tuberculosis, education is the most important thing, I think, that will be the most crucial thing in eliminating tuberculosis. Simple measure of cough hygiene or cough etiquette, it will be a very great thing if we can reach out to our common citizens, common people, that they should not cough, they should not spit in public places, and they can cover their mouth while coughing. They can cough by going to a distant place, and they should not spit at public places like offices or trains or buses, etc. So I think educating and having awareness camps like health camps, like school children, we can educate school children right from the beginning. We can have some educational programs in the schools and educate our children. So that will be also a good thing, and that is a very need of the hour thing, I think. Also, we can have health camps in various remote places, like, or in say jhopatpattis, or like Dharavi in Mumbai, or any slum areas. Any slum areas, we can have health camps. We can have active case findings with teaming with our community health workers and Arogya Mitras. Also, we can use digital platforms like Nikshay. We have Nikshay web portal to track our TB patients. Even there is one app called TB Arogya Sathi app. Thereby, the patients, they can use this platform to know the tuberculosis, know the symptoms, how to take care of their cells, how to have some etiquettes or nutrition status, how to maintain nutrition status, good nutrition status. And also by creating, we all are on social media as of today. We are using social medias. So everyone having a cell phone is on social media, at least on Instagram, WhatsApp, Facebook, Twitter. So I think these social medias can play a big role in creating awareness. Like on WhatsApp, we can share our statuses about the disease, particular disease, or anything. we can use the social platform and aware our close friends or our relatives about this tuberculosis. So I think
And that's
communication, community outreach,
great.
and social platforms like all these I have discussed, they are the game changers in the coming fight against tuberculosis, ma'am.
Absolutely. So very well said. As we know, TB is difficult to eradicate because it's a communicable disease, highly infectious disease. So first of all, we have to tell patients what are the symptoms of TB and when they need to come for help. And if at all they have TB, we have to tell them free treatment is available. We are giving
Yes,
incentives.
ma'am.
So
Yes,
very well
ma'am.
put up by Dr. Anil. He spoke about the different apps, etc., where all the information is given. And at the same time, we also have to tell people how to improve nutrition, the cough etiquette, etc. So very, very importantly said how to prevent transmission. So very good. Thank you for this answer. So now I'd like to come to Dr. Narayan Pradeep. So again, Dr. Narayan Pradeep is our he is basically one of the founder members of our CCI, and he has been really carrying entire baggage of CCI on his broad shoulders. And he is again so committed to CCI and equally committed to TB, and he is doing fantastic work in Kerala for TB. So we would like to get very important information and his words of wisdom from Dr. Narayan Pradeepa. So can you please tell us what is the impact of substance abuse and mental health on TB prevention efforts in high-risk populations? Like, for example, people who are drug addicts, HIV positive, etc. So how would they have, what would be their chance of getting TB and what would be their response to TB treatment? Would that be any different?
Yeah, basically they are immunosuppressed. So definitely the chances of TB infection progressing into TB disease is very high among them. Second thing, they are very much not receptive to our approach. Drug addicts, they when we tell something, they may not listen, and they will immediately refuse for coming to the diagnostics, coming to the or taking to the treatment. They may take for 1 week, then leave it again. They may become chances of becoming defaulter is very high. Number three, they are more like spreading the disease among themselves. They will be having some closed groups of themselves, and they will not have any hygiene or anything like that. That is the third thing. They will be sources of spread for others. And actually, substance abuse is now alarmingly increasing in our state, and we are having a lot of programs, even in the school, right from the school levels. We have started a lot of with the police, with the Janamaitri police, then with the social local self-government. So we are having doing our level best to control this menace of drug abuse in our state. And regarding HIV, actually the number of HIV patients with the TB is if we compare 10 years or 20 years back, it's little less. Maybe HIV is well controlled now. We are not getting that much cases. And people living with HIV are living better quality of life than earlier 10 years or 15 years back. So reinfections are really less now with the advent of the lot of antiretroviral drugs.
Correct. So very well said, because they are immunosuppressed, because they are living crowded, they have a higher chance of getting infection. And the other thing about drug addicts is that they are likely to not complete treatment. So the chance of relapse are more, chance of acquired drug resistance are more. And in HIV in particular, very often there's a problem with absorption. And therefore, even if they are compliant, very often the drug may not be absorbed well and they may get acquired drug resistance. And therefore, very well put up by Dr. Narayana Pradeep that we have to really watch these patients well. And luckily, as rightly said by him, patients on HIV are living much longer and the outcome is much better. But this is a particular group that we really need to watch even more than we would otherwise watch. So thank you for the reply. Now I'd like to come to Dr. Mahesh. So again, Dr. Mahesh requires absolutely no introduction. One of my favorite people, extremely academic. He belongs to, we have the same alma mater. Our teacher is common. Absolutely very, very academic and always smiling, always there for me. And now he's moved to Calcutta, so we are very depressed. But I'm sure Calcutta people are rejoicing and celebrating to have him there. So I'm going to ask you something very, very interesting. So Mahesh, please tell us that is it mandatory to give leave for every TB patient, number one? And which forms of TB require leave? And do we have any state government rules or central government rules about this? Please tell us.
Okay. First of all, ma'am, thank you very much for your generous introduction. And you're always supportive to all the juniors and everyone who is connected with you. Ma'am, first of all, about the tuberculosis, I would say that every TB patient does not require a rule. And as per a rule, there are no special rules are there for the TB patients, unfortunately. And one has to follow the law of land because the state-wise there are some changes in the leave rules. So we have to check your own states what are the different rules, or is there any different rule for the tuberculosis. However, for the in Maharashtra, because I have worked in Maharashtra and Mumbai, so there usually for sputum positive patients or severe forms of pulmonary tuberculosis patients are given leave, the paid leave maximum up to 6 months, beyond which they may get a leave, but it will be unpaid leave. However, in West Bengal, there is a something known as a paid leave for disability, which is maximum up to 24 weeks. And usually there is one committee where if it is proven that he has suffered due to tuberculosis as a part of his occupation, so he may get a leave, and the committee decides on the prefix parameters of where does he work, what are the symptoms, and what is the disability, and then he may get a leave. However, in the central government, there are no special leaves only dedicated for tuberculosis. However, it is like a general medical leave rules, but there is one caveat which is known as a work-related illness and injury leave, where the person can get a paid leave up to 6 months, and beyond 6 months he may get a half pay leave. So total he may get 18 months of leave.
So this is very important. Yes.
And ma'am, one thing which what I follow is about the general rules, because we may get a patient who is a government employee as well as he's a private employee. So there are no separate measures for the private sector. So if person is a sputum positive, highly infectious, then he can be given a leave for at least minimum for the 2 weeks. But if he may not continue his leave for up to 2 months, then he should be asked to wear a N95 mask and go to a work. As we all of us know that the ATT decreases the infectivity very rapidly. Plus, if it is a government sector, then we can give leave up to for the 2 months if it is severe forms of pulmonary tuberculosis or severe forms of extrapulmonary tuberculosis, or if it is in simple forms of extrapulmonary tuberculosis, but if he is having an intolerance to ATT or some ADA, then we can give him some leaves.
Great. So this is very, very important that every TB patient, even if sputum may be positive, if he is not asking for leave, then you are not forced to give them leave. And it's very, very unfortunate that sometimes they want to work, but this advising them for N95 is quite mandatory. And it's very important to know that leave up to 6 months, paid leave up to 6 months could be given to many patients. And we need to do this. We need to know this because many patients are government patients and they are actually eligible to get this, but because we don't know, we don't end up giving them. So I think this was a very important point that has been brought out. Great. Thank you, Mahesh. Now I'd like to come to one of, again, my very favorite person, none other than Dr. Indu Bubna, who is a very, very active member of CCI, an extremely charming lady, always smiling and always wanting to read more and more. So she does fantastic work in Bombay, and it's great to even meet her, outside conferences. So Indu, basically a question, for how long a patient should be advised to use a mask if the patient is on AKT, number one, and how can private providers offer social protection in TB? You are muted.
Thank you so much, Amita ma'am. You have been always encouraging towards everybody, I feel. So I just like your nature a lot.
Thank you.
I'm a fan of yours, actually. I can say that. Thanks for the question. So regarding the mask, I want to say all TB patients need not wear the mask. In case of extrapulmonary TB, whether it's brain TB, spine TB, or any other TB, we don't have to wear the mask. Only for the pulmonary TB cases, because it is spread through the droplet infection. It's through cough and sneeze. That's why mask is mandatory. And it is advisable to wear a mask for at least 2 weeks so that the infection rate goes down.
Correct.
And regarding the second question, how social providers can offer social protection, the private providers can basically provide social protection by actually implementing certain things. which is, as we all know, that education is lacking, the TB awareness is lacking in our country. So targeted education and awareness is most important about the symptoms and signs of TB, because the symptoms and signs are so vague that it mimics other respiratory illnesses. So that one thing, how to kind of reach the private practitioner or their doctor early in case of the TB symptoms and signs, how to prevent the transmission, as one of the panelists just mentioned, how to prevent the transmission. And other than that, patient education and awareness, we can provide the financial support, nutritional support, the social support, which is very, very important. TB patients actually lack family support and community support. They actually get discriminated and isolated because of social stigma. So I feel the psychosocial support is very important, and adherence counseling that can be done at the private sector. Then regular follow-up visits are very, very important. Then we have to also address the social determinants of the TB, like Dr. Animesh mentioned, the poverty, malnutrition, poor housing, which can actually lead to a negative treatment outcome. So we can actually connect the TB patients to the social welfare schemes, which provide support for these patients in terms of food insecurity and poor housing conditions and all that. Also, there is a lack of awareness of the TB diagnostics. So I feel that awareness and access to the TB diagnostics and free TB diagnostics is provided by the government. So the awareness about what they can avail, what benefits they can avail, creating that awareness is very, very important.
Yeah, very well said. Completely agree. I liked one thing very important, that TB patients are really discriminated. So if the patient has any illness, whether it's asthma, cancer, anything, family is always around them, trying to feed them, trying to sleep with them, hugging them. But if it's TB, everybody wants to be away. So it is kind of really very, very depressing, because you're not really feeling well, and at the same time you really lack the human company in the touch. So very well said. And I completely agree, masking is required for 2 weeks. I would just like to add, provided it's sensitive TB, if it's resistant TB, then of course the masking will be for at least 6 to 8 weeks minimum, ideally for 12 weeks. So great. This was wonderful, Indu. I'd like to come again to Dr. Animesh. And again, as we know, Dr. Animesh is just so committed to everything that he takes up. So this is a very, very interesting question, which a lot of us need to know. So very often people are like, I have TB, but I'm breastfeeding my child. So what should be basically, if the breastfeeding mother has got TB, then what advice are we supposed to give her to prevent transmission of disease to the newborn baby? And for how long should she be maintaining and following all the advice that we give her?
So thank you again for that question. I think very, very apt question. The thing is, especially in developing countries like India, let me say that first, it is advisable that breastfeeding continues. And especially again in the case of TB, there is hardly any evidence that there is a lot of bacteria is in that mother's milk. Hardly any. So we advise that she continues breastfeeding. However, if she's having a drug-resistant TB or she is on treatment, again, the drugs are not really excreted or secreted in the breast milk. So there is hardly any toxicity. The toxic levels are very less. So again, she can continue breastfeeding safely. Only if we are thinking that probably this could lead to, because other ways mother can infect, then we'll have to think of some ways where she can protect the child. But otherwise, breastfeeding should be continued. Having said that, if she's taking treatment, within 2 weeks, she will be non-infected. We know that. So she can again continue. So ideally, it is good, and especially in our country and countries which are developing countries, as I said, it is actually advisable that they continue rather than stop breastfeeding. This would be my advice. Even the WHO says that, because they say that the mother's milk does much more good than it can do something otherwise. So that is something which I would, everybody should remember that. And if at all we want, we can give chemoprophylaxis to the infant, if at all. But that's also not always warranted. Another thing is that if at all there is a concern about drug resistance or the mother being infectious, sometimes it is also advised that maybe express breast milk can be tried. But as I said, it is much better to go ahead with the breastfeeding, and especially those mothers who are drug susceptible or no longer infectious, this is definitely a good idea to continue with breastfeeding. Best would be to initiate them on treatment and render them non-infectious as soon as possible, and let them continue with the breastfeeding.
Great. So I completely agree. Basically, it is said that we have to encourage breastfeeding. The mother should be wearing an N95 mask while she's feeding the baby. And this breastfeeding is important because the breastfeed is healthiest for a newborn. It provides all the nutrients and also immunoprotective agents much more than any top feed can. And therefore, and also it helps in building up the emotional bond between mother and the baby. And very often, mother could feel guilty many years later, and blame herself for this. And if there's too much of a problem, then it can always be expressed milk. So the thing is that definitely this can be done, and wearing an N95 mask would be great. And I would basically feel that though if it's even sensitive TB, I would say that though for normal people we say mask for 2 weeks, for a newborn baby who has absolutely no immunity, probably then there's always a high risk of dissemination. I would recommend that mom should be masking at least for 2 months, and she should be taking all the precautions for at least 2 months for sensitive TB, because we are worried about dissemination of TB in a newborn. So great. But the bottom line is that the breastfeeding should continue, but mother should be wearing a mask. Great.
True.
Yes. Thank you, Dr. Animesh, for this answer. Radha, back to you. So, most of our patients ask us, that I have TB, but now I don't want my family to get TB. So, can I eat with them? Can I sleep with them? What can I do to make sure? What do I make them eat? What do I make them do so that I can prevent my spread of infection to them? So, what is the advice that you will tell them to follow to prevent TB in their family, and also about the nutrition that the family should take?
Yes. Thank you for that question. As we all know that by the time a diagnosis of tuberculosis or a sputum positive case is made, the patient has already infected 10 or 15 people around him or her, right? But when we talk about the family are the people who are living in a closed environment and is being exposed to that patient for a longer duration of time. So it's a closed environment and a very long exposure.
Correct.
So
Right.
there are 2, 3 different ways in which we can counsel and advise the patient. So let us look at how to prevent the infection. So let us look at the patient's, what can be done from the patient side. Sorry for that. We have all learned and we have practiced during COVID times. So home-based isolation is fairly possible for at least 15 days to 1 month. Because once anti-TB treatment is started, by 2 weeks, the number of bacilli has gone down drastically. And even the most of the bacilli which are coming out would also be dead. Not all, but most of them. So that is one thing. So I think home-based isolation, if possible, is one good thing which can be adopted. Second is the patient himself should be wearing a mask. Other family members should be using N95. As per guidelines of airborne infection control, the patient should be wearing at least a simple or a surgical mask, but the other contact should be wearing N95 as far as possible. Third important thing from patient's point of view is sputum disposal. So we must advise not only the cough etiquettes or cough hygiene, but also about how the sputum should be disposed, because it's an infective material. So either they spit in a tumbler or a cup which has hypochlorite solution, or can I have a glass of water, please?
Drink some water. I'll ask a question to somebody else,
Yes,
and we'll come back. Yeah.
I have.
Please have water. Okay. So it was fantastic the way Radha was answering. But I think we'll just let her take some rest.
Yes. No, I'm perfectly all right.
Okay.
Second thing is sputum disposal is very important. So in the cup where the sputum is being collected, they can put hypochlorite solution, or after when they want to dispose of, first it should be made non-infectious and then disposed of. Another thing is they can even burn, but that is not advisable nowadays. So we always ask to disinfect. So this is from the patient's perspective. One, I have told how the family members should be using N95. Another thing is, if all this is not possible, then we ensure that the patient is in such an area where there is frequent air exchanges. So you should open up the windows and the doors which are possible to be opened up with a fan working so that the air exchanges keep on happening and the load of bacilli which are likely to infect the family members fall down and does not cause a disease. That is one thing. Another important thing is they are all stressed up. They should have good food, good sleep, and should be trying to avoid the anxiety of whether I would be getting this disease. And third, most importantly, because all these are close household contacts, evaluation for latent TB infection, and if they are willing to take, we should be able to offer TB preventive therapy to them. If at all anybody has LTBI or anybody who is at a high risk, like diabetic, hai, somebody on anti-cancer drugs, hai, or even some HIV if in the family is there, then they should be offered TPT.
Wonderful. One very important point that Dr. Radha said is that, by the time the TB is diagnosed, they are going to infect if they are supposed to infect. And the first dose of, so basically, I just want everybody to know that when you are counseling the relatives, you just have to say that by now you have got infected. So you want to prevent disease from happening. And therefore, you have to just make sure your immunity is very good, sleep well, eat really good food, make sure your vitamin D3 levels are good, and over and above everything else that Dr. Radha said, fantastic. And very often
And
tumblers
one thing, if you have good doctor, leave everything to your doctor. Don't worry. Be tension free.
no, I think that we have to be watchful, and I basically also feel that, to keep a tumbler and all is not always possible. Very often we have patients who are spitting in the basin. So we have to say that as soon as they spit, they have to continuously keep on running water over it so that nothing really stays back. So I think this would be great. So thank you, Radha. Despite your cough,
And now you have those sputum cups also, which solidifies immediately if you spit into that. And then they can be disposed of.
Great. Yes. So now I'd like to come to Dr. Anil. So Dr. Anil, basically, Dr. Radha mentioned about the TPT. So I want to say that, ours is a high burden country. So can you tell me that how much is TPT really going to affect a high burden country of ours? And if we want to give TPT, then what should be our target population?
Ma'am, this new thing TPT has introduced by NTEP. This is also a very crucial thing, ma'am. I think almost 30 to 40% of the Indian population is already infected with TB bacilli, and the lifelong risk of development of active tuberculosis disease is around 10%, 5 to 10%, ma'am. So these patients, they are also going to have tuberculosis in future. So targeting such population, especially in India is a huge country, ma'am, huge population, but at least some people amongst these people who are at high risk, ma'am, like household contacts, patients on immunosuppressive therapy, people living with HIV and on or who are on ART, patients on anti-TNF alpha therapy, and I think solid organ transplant patients, even these patients on dialysis, all these patients can be put on TPT, ma'am. TPT is focusing on, I think, prevention of and cutting the transmission chain of infection, and that will be a key milestone in achieving this TB elimination, ma'am. So it's a very good thing, but the high risk population should be targeted, ma'am.
Okay, right. Very, very well answered. Absolutely perfectly answered. And I would just like to add that before starting TPT, please examine the patient.
Yes,
And
ma'am.
make sure that the patient doesn't have active TB. This is my own opinion. I basically feel that I don't know how good TPT may be because there's about 16% of primary INH resistance. And therefore, we really don't know people who are giving TPT are going to be INH resistant or not. And if at all we're going to give INH rifapentin, we might just end up causing rifapentin resistance. And the third regime, levofloxacin, we don't know there's 40% levoflox resistance.
Yeah.
So I'm really not sure how useful it is going to be. But I basically feel that if we make sure that there's no active TB, then giving at least will not have much harm.
Yes, ma'am. Selecting the right patient is the key,
right
ma'am.
patient is very
Yeah,
important.
ma'am.
And ruling out disease is very, very important.
Yes,
And I
ma'am.
think
Yes,
that
ma'am.
is something very important that even our program needs to really concentrate on. It is not about how many people are enrolled into TPT, but it is all about how many people are
Yeah.
correctly enrolled into TPT. So thank you. Very nicely
Yes.
answered, Dr. Anil. And you actually mentioned about all the high-risk population who should be considered, if at all, for TPT. Great.
Thank you.
So thanks. Yeah. Again, now to Dr. Narayana, Pradeepa, because I would like to specifically address this question to you because Kerala state is doing really fabulous as far as TB is concerned, and y'all are just so much ahead of us. And I kind of feel that y'all are completely in the state of making guidelines and leading the path for us. And I believe that TPT is maximal happening in Kerala, and the amount of TB is least in Kerala. So you are the best person. Can you please tell us about the different TPT regime currently approved in our country? And you also tell us if you all use anything over and above this.
Yes, madam. Before going to TPT, as you rightly mentioned, active tuberculosis ruling out is very, very important. For example, in one family, we have yesterday only, patient had a sputum positive tuberculosis. His wife is having pleural effusion and his daughter-in-law is also having pleural effusion.
Oh, wow.
So it is like three people in the same family. So ruling out active tuberculosis is very, very important. Maybe may not be sputum positive, it may be extrapulmonary tuberculosis.
Yes.
Another family, last week we had one brother is sputum positive. His sister is having a cervical lymph node when doing examination. Then we immediately sent her for FNAC. Then it also came as positive. So the first and foremost thing is ruling out active tuberculosis is very important. Second thing, as you mentioned, as we have seen, incidence of tuberculosis in our state is little lesser compared to other part of the country. What we have examined is we have examined the sales of the drugs in the private sector. It has drastically reduced in the last 4 or 5 years. So we thought we can go ahead with the TPTs, TB preventive therapy. Then what we have examined is number of notification versus number of the tests diagnosed, number of the sputum tests examined. So that is also number of the sputum tests is increasing, whereas notification is coming down. That also indicates that there is a slightly lower incidence of tuberculosis. With these 2 points, we started with the more aggressive TPT regimens. So we have a TPT for drug-sensitive tuberculosis as well as drug-resistant tuberculosis. In drug-sensitive, we have, as you mentioned, INH alone we are giving. And in drug-sensitive, drug-resistance cases, if it is, depending on the index cases, drug resistance pattern, if it is INH alone resistance, we give only rifampicin single for 4 months. And if it is MDR, then we go for 6 months of levofloxacin. There are 2 categories of drug resistance TPTs. And coming to drug sensitive TPTs, we have in our state, we have 3 categories of patients. One is less than 5 years. Less than 5 years, we give INH alone, irrespective of whether they for 6 months we give INH alone. Then above 5 years, 5 years to 15 years, we rule out active tuberculosis first. Then we do a test called either IGRA test or any other tuberculosis sensitive test like CY DAT test. Then if it is positive, then we give INH and rifampicin for 3 months. That is not in other parts of the country, but only in Kerala it is there. And above 15 years, we do the same IGRA test or CY DAT test. When it is positive, we give once in a week INH and rifapentin. That is 3 HP regimen. And now we have sufficient medicines, but the guidelines tells that if there is no sufficient medicine, we can always go for a 6H regimen in any one of these cases. INH alone for 6 months.
Wonderful. And even levofloxacin could be given.
We have a little because I am in the other side, program side, we have little concerns when we give
absolutely alone. A lot of yes, we have a concerns.
As you told, 30 to 40% resistance with the levofloxacin alone, it's very difficult to. And
yes,
the more important thing is other family members. If they are giving them education is very difficult. They are telling I am having absolutely no symptoms. Why I should take treatment? And chances that they miss the treatment is very high. So even for say, for example, when we get cough, cold, the doctor prescribes 5 days antibiotics. People will not take for 5 days also. So taking TPT for 6 months, they are missing the tablet because they are not actually patients. They are
absolutely
normal people with the TB infection, but they are not. Chances of missing are high.
So, I live in Bombay and I work in a tertiary care center. So we are little like, so the thing is that if at all, first of all, I don't believe honestly in giving TPT. But if a patient comes that I want TPT, because there's a positive patient, very often they didn't come. So we actually just don't do X-ray and clinical examination. We actually do a full body PET CT. Because the thing is that sometimes patient could have a subcarinal lymph node and a chest X-ray will never show it. So patient has no symptoms, X-ray is normal, and you'll end up giving INH alone, or you'll end up giving INH rifapentin. So I basically just want to say that this ruling out of active disease is very, very important. But we just need to know that that despite not having any history or symptoms, and despite having a chest X-ray, we can never really be sure. So if you have the ability to do higher tests, then please do higher tests, because as Dr. Pradeep rightly said, without any symptoms, they are taking 6 months of treatment. And then what if they were given INH prevention and they had INH drug resistant TB? Then they might get TB and then they have to take TB treatment again. So I basically feel that, according to me, it's very, very important to identify active patients, treat them correctly with correct drug susceptibility. I just feel personally that till we don't complete that, at least I personally feel that in a city like Mumbai, where we are the TB capital of the world, we will not really think about TPT. But of course, in Kerala, they can, of course, afford to do all this because they are doing brilliantly well. So thank you, Dr. Narayan Pradeep, for this answer. And to know about 3HR was interesting because, it is recommended at other places. Our country doesn't still say it. So I'm sure your results will make our country make guidelines. So great. Thank you. Now I'd like to come to Mahesh. So Mahesh, basically the thing is that we just know that program is doing just so much, and they want to give incentive not only to the patient but also to the treating doctor. So can you please tell us what incentive will a TB patient get? What incentive will the doctor diagnosing TB get? And are these incentives different for drug sensitivity, drug sensitive and drug resistant TB?
Yes, ma'am. Unfortunately, about the incentives, government doctors are not given any incentive for diagnosing or treating any kind of tuberculosis. However, in private sector, if doctor diagnoses a tuberculosis and it notifies, he gets around 500 rupees for the notification, and he gets the 500 rupees after completion of the ATT, and that too after submission of everything in the Nikshay portal app. Again, from a patient's point of view, initially patient used to be given 500 rupees per month during the treatment duration. However, now it has been increased to rupees 1000 per month as long as he is on TB treatment. So for drug sensitive TB, it is for 6 months, and then for DRTB, as long as he is on treatment.
Right. Wonderful. That's great. So, Anil, you want to say something? Did you raise your hand? Okay. Sorry, I thought you. Okay, fine. Okay. So, thank you. So, this is interesting. But what is really interesting is that the government doctors don't get paid and the private doctors get paid.
Yeah, that was interesting actually.
Yeah,
Also, one point like Mahesh mentioned, the fees of this thing has increased from 500 to 1000 now.
Yes.
And if for any reason the patient has to extend the course, then the paid thing is extended also.
In fact, we have this TB now. We have TB Poshan Yojana. So actually, at the time of TB diagnosis, 3000 is given to the patient, and then every month we are giving 1000, and at the end of treatment, 3000 again is given. So that is what is being done now. Means it is recommended. I don't know if it's really being done. I know about the $1,000 that is being done. I don't know about the 3000, but the program mentions that they plan to do it. Okay, so now I'll like to come to Indu. So, Indu, what measures can be taken at a private sector to improve adherence and treatment outcomes?
So to improve the adherence, basically, again, the patient education and awareness is most important about the symptoms transmission, how it is spread, and why you need to adhere to the treatment. What is the importance of completing the treatment? All this information patients should get in the first consultation in a very simple, clear language, which is understandable to the patient. You have to build that trust with the patient so that the patient understands about TB completely. They don't have to Google search or do anything other than what they are, asking you. Second is you have to address the social stigma. Many people think that TB is contagious disease. So there is a social stigma and fear which is attached to this. Even the people get scared when a pregnant lady gets tuberculosis, or their children get tuberculosis, or females of the marriageable age, they are getting tuberculosis. So you have to say it's a fully curable disease. It's not contagious, and you just have to wear a mask, for the infectious period, so that it doesn't spread through cough and sneeze. So that is again one point. Then adherence counseling is also most important. You have to tell the patient that you need to adhere to the treatment to avoid the drug resistance. You have to do regular follow-ups with the patient. You can tie up with the public sector to avail the benefits, like financial burden can be taken off because patients are getting paid, as Mahesh and you just discussed about that. And nutritional support, patients are getting these sachets, they're getting, so nutritional support is provided. Psychosocial support, private sector can provide, because government sectors are heavily worked up, they are very, very busy. So I think that load can be taken off by the private sector. And of course, the social determinants, you have to look into address the poverty, poor housing conditions. So you have to tell them that good ventilation is important. As initially Dr. Radha also mentioned that whenever the sunlight comes, you need to keep the windows open. These are extra things which you can tell the patient, connect the patient with the social welfare schemes so that they can avail the benefit. That is most important, I feel. So this is
Yeah, wonderfully said. One other thing I just want to add that we have to tell patient that you to be regular, not only to avoid acquired resistance, but more importantly to prevent the relapse. And therefore, we have to tell people that if it's malaria, you give 3-day treatment. If it's pneumonia, you give 10-day treatment. But for treatment of TB, it's 6 months, because TB is notorious to come back. And therefore, we have to say if you don't take treatment properly, you can always get TB again. So that relapse part is something we can probably scare them about. But great, you spoke everything just so well. And I thought that this partnership with the government was very, very important, so that, the patient continues with you, but can also avail all the benefits. So great, Indu. Thank you for this answer. I'd like to come to Dr. Animesh. I did give part of the answer, but I'm sure he will give us much more information. So what is Nikshay Poshan Yojana?
As you've already said, so Nikshay Poshan Yojana actually, because there was, just to give you a little background, there was a large study which was carried out. In fact, there is a role of Mangalore physician as well in that. So Dr. Anurag Bhargav and team carried out a study, and I know him personally, and they have done a wonderful study which showed that when we improve the nutrition, there is improvement becomes better, they recover better. So this was a large study which was done. Having said that, so what they did was they decided that why don't we factor this in and we bring in nutrition component, and especially when we talked about the initial part, many of these patients are poor, they have poor nutritional status, low immunity levels. So it was decided to build in a component where these patients who are registered on the Nikshay portal, they get, as you rightly said, now started with 500 rupees, but now it's 1,000 rupees a month, which is given to them. So 1,000 rupees is given to them for the nutritional supplementation, and they get it. So this is the idea, and this is done for all the patients, and it is by direct benefit transfer. So again, what happens is the patient directly gets it. It's no like middleman, nothing. So it goes directly to the accounts of the patients, and this is a very good scheme because this can help them to get nutritive diet, and it also helps them in financially substantiating it, because many a times these people are not able to afford it. I'm sure that the actual programmatic details Dr. Narayan Pradeepa might be able to pitch in with, but this is what is the very good scheme which is given to the patients, and it is all the patients are eligible for it once they are registered.
Wonderful. Great. So this is actually very, very important. And I think it's a fantastic thing that is being done, because, TB often affects poor people. And, just like we assume it's so easy to eat food, it really isn't. And I think this is something very, very beautiful. So thank you for this lovely answer. And I like, Dr. Animesh, the history that you gave. And the doctors who've really done this study. So that's amazing. Okay, now coming to Radha. So, Dr. Radha, can you tell me what is Nikshay Mitra Yojana?
Yes. I'm taking ahead what Animesh has said. And before Anurag did his study, we have had a wonderful workshop on TB nutrition, and so much of thought was put on which way we can really give a good nutritional support to TB patients. And many aspects were discussed, wherein whether we can, connect them and they can get it from the local ration shops and so on and so forth. Many of these things and many aspects were discussed at that time. So coming back to Nikshay Mitra, Nikshay Poshan Yojana gives monetary helping, which goes as a direct benefit transfer into the account of the patient. And sometimes it may take a longer time, though for 6 months it's given, but it may get delayed for one reason or the other. बहुत बार patient passbook का xerox ही नहीं देते. They think this is something like people want to know how much money they have in the account and they won't get. So there are difficulties. But Nikshay Mitra is something which you, me, everybody who is on this panel, as well as all those 1140 logins or those 10,000 plus CCI members, each one of us can become a Nikshay Mitra. So what is Nikshay Mitra is that you take the onus or responsibility of giving nutritional supplementation in kind and not cash, in kind to a particular patient and ensuring that he will get it for all 6 months. So we have calculated on an average this basket, which we call as a nutritional supplementation basket, costs somewhere around 600 rupees to 800 rupees. And this is just augmenting the supplementation to the diet. So it necessarily contains chana dal, moong dal, other, beans which can be sprouted and has an increased protein content. It has soya vadi. Then you need definitely to add some form of oil for
Okay.
obvious reasons. Yes, they need to have
Right.
good fat also along with that, and jaggery and peanuts.
Okay. Wow.
So these are important components, and at least 1 kg is there. So the approximate cost is somewhere around 600 to 800. It depends. You can add more, but this has been outlined as the minimum things which must be there. And for all obvious reasons, we understand it has a high
Wonderful.
protein content, whatever we
Yeah.
are giving.
So the government is definitely trying to do a lot to
The
support
only
people.
thing is that when you are giving, say, so for example, tomorrow CCI decides to adopt 400 patients in each state, example. But this will go to the patient who has accepted it. We have to ask him. There is a dignity attached. So you will ask, when we offer this, are you going to take this food basket? And if they say yes, then we link them and this is distributed. And in every city, I think, and most of us are already Nikshay Mitra. Once we fill up the form or decide to take up the onus, you can take 1 patient, 10 patient, how many as you want. But ensure that you would be giving for 6 months. ऐसे नहीं होगा कि 20 लोगों को 1 महीना देके रुका देंगे. You
Right,
give to
right.
less people, but ensure. And most importantly is that you have to register after filling the form and you get the certificate that now you are Nikshay Mitra.
Okay, great. So Nikshay Mitra, for doctors. Yes.
Yes.
Yeah, Indu, yes.
Yeah, I just wanted to tell that patients are actually not aware of this Nikshay Mitra Yojana too much, they're not able to, because they're not aware, so they don't get the benefit
Still, I
also.
just feel that, but one thing is very, very good about the Nikshay Poshan Yojana. Whoever gets TB, basically, the thing is, the minute you notify them, they get a message that you are
Yes.
eligible to get 1,000 rupees a month. So please give us your account details and we will transfer money. So that is
See,
something very, very good.
right. So what Amita said is very important for all of us to know that whichever is the patient, whether he's in private or public-private mix or corporate, wherever, all patients put on anti-TB, pulmonary or extrapulmonary, should be notified to the CTO, DTO, whichever is the agency. They would take details, see that they're filled on a Nikshay portal, and once their name is filled and the data is filled, then only their accounts are linked for debiting.
Great. Okay, so now the thing is that coming to Dr. Anil. So, Dr. Anil, we are talking about Nikshay because our Prime Minister is so keen that we end TB at the end of 2025. And therefore, we basically know that we have to prevent transmission of infection from an active patient. So, if we have a patient who's sputum AB positive and he's working in an office, which is really a crowded office, which doesn't have good ventilation. So, the thing is that you tell the patient that you're not supposed to go to work, at least for 2 weeks, because you're infective to others, but the patient doesn't want people to know that he has TB and he continues to go to work at the cost of infecting so many other people. So, is any judicial law or any action that can be taken against these patients?
Ma'am, actually, our constitution itself gives every individual or every citizen of India the right to health, right to treatment. These are our inborn laws, or say judicial laws. They are imbibed by virtue of our Indian citizenship. But it is also the right of that individual to notify or to convey his health status to his, say, his office or his employer, that he is suffering from this and this and this. I think there is no any punishment, or there is no any such thing which punishes that particular patient if he fails to notify or fails to tell the status of his disease. But I think we all know the TB is a notifiable disease, and once the patient is put on treatment, it's every physician or every doctor will notify the disease, and the system will come to know that particular patient is having tuberculosis. But ma'am, I am unaware of the any law to punish to that particular patient if he continues to work in spite of having sputum smear positive tuberculosis,
No,
and
you're
he
very right.
misguides or say he hides his disease, ma'am, because
Yeah,
this
that's
is
so
also
yeah. No, you're
yeah,
absolutely
ma'am.
correct. In fact, I put this question to you because the thing is, just a minute, Ramesh. I basically put this question because I just want us to understand that because we also want to eliminate TB, we also want to prevent transmission of disease because we are the ones who has highest chance of exposure to TB patients. So the thing is that because the government cannot punish, we have to basically make sure that we counsel our patients just so well and we counsel the family just so well. It could be also at the cost of fearing them about the medicine, saying you'll get side effects if you go to work for 7 days, blah, blah, blah. You just put anything in their head, but you just prevent them from going to work because we all know, to wear an N95 mask is not possible and they are not going to wear a mask. They don't want people to know they have TB and they're going to sit and eat with each other, talk to each other, etc. So I kind of feel that because there's no law in our country to punish these people, we have to basically take on to our responsibility even bigger. And it's not only about writing the correct equity, but it's also all about teaching the patient and educating the patient and the family to avoid such a situation from arising. Yes, sir. Mahesh, tell me.
Ma'am, as a medical practitioner, we have been taught in forensic medicine that professional secrecy is the one we have to maintain, and the notification of infectious disease is one exception. But
Yes,
if the patient is not using a barrier or not using a mask and is potentially infectious, you have all the rights to inform to a employer or his higher authority in a confidential way.
absolutely. Absolutely. Very, very important point. And I think we should do it if somebody's doing like that because we owe it also to the society to protect them. So great. Coming to Dr. Narayana Pradeep. So this question is especially for you because you are doing just so well about TPT, etc. So how would you strengthen household contact investigation?
It is very important, madam, because I work in a very peripheral settings in a district TB center. We do house visits as well. Along with I have sent, and that is how, because our system works like that only. Maybe in the corporate hospital or sitting in the tertiary care, it is not possible. But in a district TB center, who we are working, we do house visits, or at least my staff will go do the house visit, and we actually get the numbers, not just the number what we put in the Nikshay.
Correct.
So we call them and we do the active case. We rule out the active TB in them first, or at least the ASHA worker in their particular house gives the sputum bottle and they collect it and they rule out active tuberculosis and they enroll for the next. They we do the active TB. Then we do the TPT testing, that is IGRA test or CY that we do. Then if that is positive, then we go give the TPT. Actually, in my place, it is working. Actually, it is public system is good, so I am happy. at least say 80% of my people are able to be able to do the tracing. Only problem with the migrant workers, as ours is a border district, and we have a lot of border issues as well. People are traveling for other places. That is that issue is there with us. Otherwise, we are able to do it in a fairly, not 100%, but at least in a manner which satisfies us.
Wonderful, wonderful. Going to the house of the patients and all, I think it's just so perfect. Wonderful, Dr. Narayan Pradeep. Superb. Great. Coming to Dr. Mahesh. So we are talking about TPT. So after being treated successfully for TB, so TB treatment is over. Does one need to take TPT for future? If yes, when and how?
Ma'am, as all of us know that anti-TB treatment is very, very effective. The relapse rate after the anti-TB treatment is 2 to 5%, and the maximum of which occurs in the first 2 years and remaining 50% in next lifetime. However, if one has
correct, I would just say that infectious after taking treatment, chance of getting TB is like 10%, but 80% would be in the first 2 years, and the remaining 20% in the rest of the life. So.
And ma'am, so that after taking a TB treatment, there is no need of giving a TB preventive therapy unless patient is an HIV positive patient. So in HIV positive patient, if there is a high risk of reactivation or relapse, then that patient can be given an extended TB preventive therapy.
Wonderful. So this is very important that normal people who have got treated for TB do not require TPT. Okay, but if the patient is HIV positive, then after the patient is completely treated for TB, basically we wait for 6 months. At the end of 6 months, we again rule out active TB. And then if at all the patient is worried about getting TB again, because they can get new infection, reactivation is gone, but they can get new infections. If they are worried, then after 6 months of stopping AKT, MANTU or IGRA can be done. And if it comes positive, then they can again be given TPT for 6 months. And otherwise, as Dr. Mahesh rightly said, if the patients have high chance of getting a relapse, if they are staying in a house with a positive patient, or if they have diabetes, or the CD4 is very low, or they are very, very old, then these patients could be given TPT over and above the treatment. So this is interesting that I think we should know. And thank you, Mahesh, for this answer. Coming to Indu, what are the barriers you have seen that TB patients face in their treatment of TB?
So basically, the barriers are about the education. Patients are not aware of what is TB disease. So I think that is one barrier. They are not aware of the symptoms, how to kind of reach the private sector or the the GP early. They are not aware that the delay can lead to the delay in the onset of the treatment. So that is one thing. Then the stigma which is attached, they feel it's a contagious disease. So then that is another thing. We have to break the myth that it's not a contagious disease. And then, of course, the lack of support which is there from the family and the community. So that is one barrier. And then the health sector related barriers are too many actually, So inappropriate treatment. We all have seen, a lot of prescriptions which are not appropriate as per the standard National TB Elimination Program guidelines. So that is a hindrance to our goal of elimination of TB, I feel. There are not enough skilled professionals on the field, I feel. So all the faculties are actually treating TB, and we see various prescriptions. So that is one. And then the patients don't adhere to the treatment because of the side effects of the TB. That is another thing. So these are various barriers which we see. Again, one important thing is sometimes the drug stockouts, we don't get, there is an unavailability of the drugs. The essential first line drugs are not available. So last year I have seen that isoniazid was not available for quite some time. So that is one thing. So these are certain barriers, And of course, the financial burden, which is loss of income, the employment, then everything, the health cost, which is there, consultation charges, the treatment cost, diagnostic cost, and then the emotional burden. So a lot of things,
Yes, so TB is very, very special, because so many things which are not otherwise related to other diseases are very much there.
Yes,
And
I feel it's not just a medical disease, it's a social disease, and we need to socially prevent it.
Address it, yes, absolutely. Yeah. Great, wonderful, Indu. Coming to Dr. Animesh. So basically, what is your take on adult BCG vaccination, and what should be its target population?
A very good question, but what I have understood that there are no something like, I can say, proven thing which says that it is definitely good. It is being given, it is being recommended, and now the government has actually included it in some of the. I think I read a report which said that about 23 states they are trying to launch in certain districts. Okay, and it's already. I think it's already started in Mumbai as well. So what they're doing is that adult vaccination is being given, and again they're looking at if people who have had TB in within the last 5 years, or they are 50 and above, or they have some risk factors. So they are the people who are the target. Having said that, again, I wouldn't say that it is conclusively proven as of now. If you look at the literature in Western country or any other place, or including African continent, we don't have a literature to support that this definitely prevents. Yes, there have been Chingalput study and there have been revisits on that in Tamil Nadu, and they said that it was to an extent it prevented to an extent, and even there was, I think, if I remember the figures correctly, 36% of the efficacy. But again, if you look at it, 36% is not a very good efficacy if you look at again. But having this question, I think I would suggest that maybe this could be tried out, and Indian government is committed to it because they are committed to eliminating tuberculosis. But as a preventive medicine specialist, my take would be that I think I would look at other factors, because having TB as a very social disease and a lot of other things coming in, I think that's also important to raise awareness, to improve the standard of living, the sanitary conditions, the ventilation, the disposal, cutting down on transmission. That is more important, I think, than this. This would be my take. I know I have digressed a bit, but I feel that it's not just.
No, you're absolutely on the dot.
The children vaccination is definitely there, and again, as we know, BCG does not prevent totally against tuberculosis. It does prevent the severe forms, the miliary tuberculosis and meningeal tuberculosis, but it does definitely not prevent only the tuberculosis infection. So that's why I'm saying that. Maybe I will be proven wrong in future, but as of now, this is my take.
No, I completely agree with you, and you've said it so well, because BCG is basically given to prevent severe forms of TB in children, because they have just no immunity, and if they have any severe form of TB, they're not even in a position to talk about it, or we can't even diagnose it, and then it could either be fatal or it leaves, terrible sequelae. So I basically, honestly speaking, also I have my inhibitions right now about giving BCG or myself taking BCG, but I hope I'm proven wrong, because if something miraculous can happen, then it'll be great, because otherwise I don't really see TB ending anytime, So this was a very good answer, Dr. Animesh. Thank you.
In fact, there is doctor, sorry to cut you, but then there is also a trial of another one which is going on actually.
Yes,
I think, yes. There is,
ask a question on it to Dr. Anil. That time you can add if you want to. So I come to Dr. Radha. So Radha, after being treated successfully for TB, like we spoke about TPT after TB, so now similar lines, after completing AKT for TB, should the patient be given an option for BCG, or should we tell the patient to take BCG? If yes, then when, how, or whatever?
Sorry, but the answer is no. After treatment, as far as I know and whatever is literature available, once the treatment is completed, we do not advise BCG vaccination. As Animesh has already covered adult BCG vaccination, which is offered to people who have already completed TB treatment also. But remember, all this is as of now in a trial mode, after taking consent from the patients. And after 2 years only, we would know the results, how far the protective effect of this has been. So the answer is no.
Speaking, the program is offering basically people again who are high risk factors, diabetics, many comorbidities. So in spite the treatment getting over, the program is actually suggesting that they could take the BCG. So, but again, I don't think I would ever offer to my patient till we get some very, very good results. So fine, okay, thanks. Now coming to Dr. Anil, moving on to what Dr. Animesh had said. Anil, are you there? Great.
Hello, hi, ma'am. Hi, ma'am. I'm here. Yeah.
What are the TB vaccines in addition to the BCG vaccine? What are the other available vaccines for TB that you're aware of?
Ma'am, there are almost 90 to 20 TB vaccines. They are in pipeline or they are in the various developmental or trial phases, ma'am. Out of these two, one is MTV vac and other is M72 ASO01. These two, they are in phase 2B trial, ma'am. So soon we will be having results of these two trials, and soon we will be having TB vaccines, ma'am. But whatever experience, small experience I have over the last 15 years about tuberculosis, ma'am, I think nutrition plays the great part
Agree.
as of vaccine, ma'am. Nutrition is the best vaccine, ma'am. So even we are now seeing very affluent society, children or the parents, they are bringing their children to us and they are diagnosed with tuberculosis only because of ma'am overeating of fast food, not having a good nutritious diet, ma'am. So
And
I think
wanting to be
yeah,
thin,
ma'am.
dieting and wanting to be thin.
Yeah, ma'am. Yeah. So I think soon we will be having TB vaccines, no issue, ma'am. But I think nutrition plays the great role, ma'am.
Absolutely. I'd like to talk about two vaccines in particular. Of course, they are still not proven, but we have this Ruti
Okay,
vaccine.
ma'am.
And this Ruti vaccine is a
Yeah,
little different because it is used for latent TB. So a person who's got
yeah,
latent
ma'am.
TB, you give them the vaccine and it does not allow active TB to happen. So I'm somehow very hopeful about this. As against TPT, where you have to take it for 6 months, you don't know whether the patient is INH sensitive or resistant to begin with. I think if this works out and doesn't have too many side effects, and this, according to me, would be fabulous. You do Mantu or you do IGRA, and if the patient has latent TB, you give them the vaccine. I think that would truly be the game changer. So this is something I'm very hopeful about. And we have this other
Yeah,
VPM 1002 vaccine, which is very, very similar to BCG, but the results are much better than BCG. So I thought this also might be. So according to me, these two vaccines are really to look out for, and I hope they turned out to be the game changer. And I really
yes,
like what you said, that nutrition is the best vaccine. And I could not have agreed more with anybody else, and it couldn't have been put better. It is all
yes,
about good food, vitamin D,
yes, ma'am.
good sleep,
Yeah,
no alcohol, no smoking, keep your immunity good. I mean, I think nothing better than that. Great.
yes,
So
ma'am.
this was interesting. I would like to come to Dr. Pradeep because he also mentioned Sai TB, and Dr. Pradeep seems to be, practicing TB in another world, where he's just so much ahead of us. So I would like to ask Dr. Narayan Pradeep that what is your take on the new test, Sai TB test, which is introduced by the Serum Institute of India?
It is very easy, madam. Even the staff nurse can administer it, and it is easy to read also. And we are not at doing in a very, not rolled out it properly, but we are doing it. And for me, it was far better than Mantoux test. I feel Mantoux we have missed something somewhere, but this is actually replacing it, and it is going to be good for identifying the latent TB
The
infections.
benefit of people, would you like to tell us what Sai TB test is?
Yeah, I can explain, madam, but with the timing is
But then I'll
it is yeah. It basically tests same like a basic mechanism, same like Mantoux test only. Tuberculin antigen test, TST, same skin test only, and we have to administer something called as ESAT antigen is there, and it will identify it. And if patient is infected with the TB bacilli, it will become positive.
Yes.
So
According to me, the best part about Sai TB is that, they don't have different guidelines, less than 5 and less than 10, etc., based on the immunity. So if more than 10 is positive and less than 10 is negative. So I kind of feel it becomes very, very easy, and it basically uses the same material as the IGRA. So the IGRA, we know that, basically Mantu has cross-infectivity. So the thing is that NTM also will cross-react with Mantu. And as a result of that, people can have falsely positive Mantu. BCG also makes Mantu become positive. So the advantage of the Sai TB is that it is specific for MTB like IGRA. IGRA is specific only for MTB. It does not cross-react with other mycobacteria. And the advantage is that it's not a blood collection, it's a Mantu test. So anybody can do it in the periphery. And you have to again read it just like Mantu after 40 to 72 hours. And the cutoff is easy. Less than 10 is negative, more than 10 is positive. So it becomes very, very easy, I feel. So we are actually not using Sai TB, at least in Mumbai. But I think it's fantastic that Kerala is so much ahead of us. So Dr. Narayan Pradeep always keeps on adding light to us about TB. So thank you, Dr. Narayan Pradeep, for this answer. You want to add something?
No, nothing.
Okay. Mahesh, you had raised your hand. You want to say something?
No, you already covered it, ma'am.
Okay, fine.
Yes.
Okay, fine. So I'll come to you now. Mahesh, I want to ask you this question that do you think private providers should be given, the chance to be writing drugs like delamanide? Because bedaquiline now is available to private practitioners. So now delamanide is the magic drug which the government has. So what is your take on this? Should the private providers be allowed to be writing delamanide? And what would be the pros and the cons?
Ma'am, this is, I think, I would say that the most difficult question of the day, because it is beyond my pay band and beyond my post to comment about the Delanite's inclusion to private practitioners. The advantage of it that it will be widely available to all the patients. And the disadvantage would be that if it is indiscriminately used or misused, there is a high chances that there would be a drug resistance to Delanite also. So I feel it should be given to all the doctors who are trained to treat the difficult cases of drug-resistant tuberculosis with the strict guidelines.
Very well said. I mean, I would have exactly given the same answer. It cannot be made open to everybody because even the best of pulmonologists are not used to treating TB. And the thing is that we don't want the drug to be misused or, abused. So I basically feel that if at all, then, in every city, 3 or 4 doctors could be identified from their past data. And according to me, there's no harm. Make them read the guidelines, take an exam. Make them write an MCQ paper or something. And because this we have in the US also, every year you have to give an exam and you have to keep on proving that you're updated with the knowledge. So I personally feel that if it's going to be rolled out outside, then we have to basically make it available to very specific people. And we can't just otherwise misuse the drug. Otherwise, it would really cause a problem. So great. And now, Indu, I'd like to ask you a question that we're talking about private and we're talking about the government. So how can we strengthen the gap between the PPP? Because we know TB is the most contagious and the most infectious disease of the century, and as a result of that, what would you do to strengthen the gap to protect us from this very contagious disease, TB?
So as you rightly put, it's a highly infectious disease and we have come a long, long way, but still there are gaps, between the public and the private sector. So I feel what we can do is, as per the strategy, we can actually include more of private practitioners. We have to engage them and incentivize the private sector to kind of, so that they're encouraged more to kind of diagnose or notify TB cases and show the treatment outcomes. We have to include various sectors of the private providers. So we can include the regular providers, also the informal providers, then the community providers, the corporate hospitals, all the caregivers basically can be included in this so that it's increased more. Then there has to be some clear-cut guidelines, or we should define the roles about what is the responsibility of a private sector and what is the responsibility of the government sector, so that we don't duplicate the efforts, and we should have some kind of accountability towards that. So that is one thing. Then the adherence support should be there in terms of financial, nutritional, social support. And then private sector can address more of comorbidities. And also I feel there are lack of there is a lack of knowledge in the doctors also in the private sector. So I feel that strengthening of the knowledge and capacity building should be there. So we need more of TB specialists. We need more of chest physicians around. And the private sector should be trained more as per the latest National TB Elimination Program guidelines. That is most important. So TB is a social disease, and private and public. See, government is doing a fantastic job. Everything is provided free of cost. Once you notify that case, So when you diagnose the sputum positive TB case, you immediately notify, to your government sector, public sector. And once you start notifying, you get reminder calls from the public sector. There are health officers on the field, which, give reminder calls twice a month to the patient. 1,000 rupees is provided for full 6 months.
Right.
Treatment, everything is covered, So I think...
Can I add?
Yeah.
Yes.
After Indu finishes, you After
Yeah,
Indu
I think she's
finishes. Yeah.
most of it is over. Yeah, Radha,
Yes.
quickly, because we have about
I
24
I
questions
think this
from the
question is
audience.
very, very. Can you hear me?
Yeah, yeah.
Yes.
Yeah, so, Radha, just little bit in short, we have 24 audience questions. I'd like to take
Yes.
all of them. So
In
just
short,
quickly, what you want to say?
yes,
Yeah.
I want to only say that if the private practitioner and the governmental agency, the CTO, DTO, whoever is, if they have a good dialogue, I'm sure each one of you can come up with your own ideas in which way the patients can be linked, apart from what has already come on the in the guidelines or in the documents. So to quote an example, in Nagpur, there is a tie-up with a hospital where they offer services for MDR TB patients. So if a patient doesn't want to go to a governmental sector, he can go and get admitted in that hospital, and the expenses which are already listed are covered or reimbursed by the DTO to the hospital.
Right, great. So I think,
So
basically
good things
important is
can
to
be
make
done.
friends. I think if you're in private, then please make friends with the government, and then you just see how best you can really benefit your patient. So I'm just going to quickly go in rounds and ask questions. So Dr. Animesh, coming to you, it's a simple one. Dr. Kailash Sachdev from Maharashtra, Jalna is asking, is TB gold interferon test confirmatory for TB? One line answers. These are simple ones.
No.
I don't think so. I don't think so.
No, I think the answer should be more affirmative. It is not
It
confirmatory
is
for
not.
TB.
Yes, it's
It
not.
only tells you about infection. It does not tell
Please
you
for it.
about disease. Absolutely. So let's give confirm more strong answers to such questions. So this is an important, interesting question by Dr. Rangarajan. Let me come to Mahesh for this. So Mahesh, there's a full case over here. Dr. A.S. Rangarajan from Tamil Nadu, Coimbatore, he's saying that there's a patient whose CT thorax is showing cavitation in few places in upper and lower lobes. Sputum examination is negative. Patient is started on 4-drug regime. He's a known diabetic and alcoholic, age is 42. He failed to take AKT for 1 week. How do you confirm the patient is cured of TB? He's cured of TB after completion of AKT.
Ma'am, what I take from the question is that he's having upper lobe and middle lower lobe cavities,
No. Yes,
and he's on ATT
upper
for
and lower lobes also.
lower
He's
lobes.
diabetic alcoholic. Yes.
Diabetic alcoholic, and he has taken ATT for 1 week.
No, he missed AKT for 1 week. So basically, sputum was negative to begin with.
Okay.
And AKT was put empirically for him. And in the bargain, only for 1 week, he's missed the AKT.
So
And
if
after the treatment is over, how do you know whether TB is cured or not?
ma'am, to begin with, that he has mentioned that it was sputum negative TB. So first we have to confirm that whether it was tuberculosis or not. If we are sure that it is tuberculosis and he has missed the 7 days of the treatment, then that 7 days can be extended to complete the total 6 months of the ATT.
Okay, so wonderful. But I just want to say one thing, Dr. A. Rangarajan, that we are pulmonologists. If we have done a CT scan, if the sputum is negative, then we must do a bronchoscopy in BAL. And we basically have to make every effort because patient is a diabetic. So this could very well be a Klebsiella infection. It could just be a staph cavitation. It could be NTM. It can be nocardia. And rifampicin is going to work on all of this. And it is not only so basically the patient will definitely do well with 9 months of 6 months of rifampicin. That is one. So according to me, bronchoscopy had to be done, and we had to differentiate between gram positive, gram negative, anaerobic because he's an alcoholic also. And about MRSA, we have to look nocardia, TB, NTM, everything. So according to me, starting empirical AKT over here is not just done. And also we want to know about the resistance patterns because if the patient has ionage resistance, then we will not be giving EHRZ. We'll have to give basically levoflox. So the thing is that it is very, according to me, we are pulmonologists, we will never do empirical treatment. And I like the point brought out by Dr. Mahesh that up to 2 weeks of gap in AKT is no problem at all. You basically just extend it, give it for those extra days, and then it should be fine. But again, over here, confirm the disease because we don't even know if this is TB. Okay, great. I would like to now come to Dr. Anil. Uh, Dr. S. Rangarajan is only asking from Coimbatore, what is the gold standard for diagnosis for TB if sputum is negative and X-ray chest non-contributory? If the sputum is negative and X-ray is not classical, how will you diagnose TB? What is the gold standard?
So X-ray is inconclusive or not contributory. So, ma'am, taking a detailed history and subjecting induced sputum for say sputum smear or
But then he's
CBNAT.
saying that sputum is negative. He's saying that X-ray is abnormal but not classical of TB, and the sputum is negative. So how will you confirm TB?
Ma'am, I can do further testing like CBNAT, or I can subject that particular individual to bronchoscopy and do BAL studies, ma'am. So we have to rule out, ma'am. Yeah.
Yeah, and only because X-ray is done, we'll also do a CT scan, because CT
Yes,
scan
ma'am.
gives
Yes,
us so
yes,
much of
yes.
information about endobronchial TB, mediastinal TB. So the thing is that CT scan in today's day and age is the next X-ray, and we must go to it. But again, the bottom line is that nothing is confirmatory of TB unless CBNAT comes positive, or you grow AB smear comes positive, or TB culture comes positive. Micro-diagnosis is confirmation of TB, nothing else.
Yes, ma'am. Yes.
Yeah. Okay, now this is like kind of tricky. I'll ask to Radha. Dr. A.S. Rangarajan is only asking, what is the value of MMR?
MMR is for
measles, mumps, and rubella vaccine.
Vaccine. What is
So
the?
it's a live vaccine, no? So it can suppress. If I can take that question.
Yes, sure, Indu, please take the question. Yeah.
So basically, measles, mumps, and rubella is a live vaccine, so it can suppress the immunity. So if we do a TST test in these patients, it can come false negative. So there should be some gap. I mean, 4 weeks of gap.
Gap of 3 months ideally.
No, madam. The question may be mass made that radiation, MMR, earlier old X-rays.
That was what I was wondering, that in this era, mass miniature radiography, which was earlier a screening tool for TB. You know, everybody did not undergo X-ray. These were small X-ray films in a roll, which was MMR. That was what I was worried.
But that, according to me, mass miniature radiography should never be done. The X-ray is just so small.
Because he is asking what is the value for MMR.
So that's what I'm saying, that it should not be done because the X-ray is just so small. There is something we will still miss it.
And now we are in an era of digital radiography. So
yes,
madam, we are doing actually one study with the artificial intelligence and with this X-rays. We have around 40 lakhs rupees on mission as from the CSR fund we have got, and we are going into the fields where we are doing those contacts of the TB positive patients. We are going to their home and we are doing this digital radiography with artificial intelligence, and we are
that is fantastic. But the small X-ray, you are
not small X-ray,
yeah,
digital X-ray with AI.
Exactly.
Earlier also, when we read MMR, we used to have those readers which would magnify it like a magnifying lens, and we could at least see the double size of that.
Yes, but I really like this point of MMR came out, because I'm very, very happy that Indu picked this up, because this is something that we are always taught. Whenever live vaccine is given, basically you should not be reading the mantu, and you should wait for 3 months, because the suppression of cell-mediated immunity. Also, if the patient gets steroid. If a patient is on steroids and IGRA becomes important, you can't do a mantu because steroids suppress the cell-mediated immunity. So I think it's important that this point got out. And I'm very, very happy.
Point of false negative mantu.
Yes, and I'm very, very happy that Dr. A.S. Rangarajan is asking so many questions, So, so Radha, I'll give this question to you now because Indu took your question. Again, we have, so we have Dr. Tridip Chatterjee, our friend Dr. Tridip Chatterjee. He's asking what precautions you take for MDR TB living in a slum.
Okay.
So quick answers. Answers.
Tridip has given a very tricky question, and probably something which he comes across commonly in Mumbai. Whatever I have said earlier about isolation in home is not possible in a slum. But then, sputum disposal, cough etiquette and hygiene, and using a mask is very, very important. And putting a patient on treatment as early as possible.
Nutrition, lighting, vitamin D.
Yes. Excellent. But in the slums, you cannot advise them to open the windows because they may not have that. So there is no point of asking for air exchanges and all. And here also comes the importance of the whole family getting screened. Family and other close people.
Again, over here, the important part is that if he was to infect anybody, he would have already infected, and therefore just concentrate on the nutrition of the relatives and the vitamin D levels. I think that would be really the best thing to do. Okay, I'd like to come to Dr. Pradeepa. Dr. Narayana Pradeepa, I'll ask you this. Dr. A.S. Rangarajan is again asking, If TB affects in pregnancy, how will you treat?
You have to treat TB. That is not.
No, so if it's sensitive TB, then we'll give all the 4 drugs, but over and above, we'll give pyridoxine.
Yeah.
Yes. And if it's resistant TB, then
Then there are multiple guidelines, sir, madam. If it is pregnancy is less than 24 weeks, we have to terminate the pregnancy. And before doing any MDR treatment, we have to do the pre-treatment evaluation. And if a pregnancy is, if there is there, we can give 2 options.
Absolutely.
And there are some modifications of the drugs is possible in MDR TB.
Like normally in the shorter regime, we don't give in the...
Yes, and we go for all over longer regimens.
Wonderful.
And basically, we have to think that there are 2 people in the pregnancy. That is what we have to keep in concept.
Right, great. Okay, actually, there are just many questions. So I'll just ask now Dr. Anil Maske. Dr. Ajay Lanjivar from Maharashtra, Nagpur, our friend is asking, does medicine provider also get 5,000 rupees for MDR?
It is not like that, madam. It is like ASHA worker MDR treatment. Those who initially when they start the MDR treatment, for the person who gives the medicine, first installment will be 2,000 rupees. And once the completion of the MDR treatment, they get another 3,000 rupees. That is totally 5,000 rupees.
Yeah,
Okay.
yeah.
Fine. So this question was for Anil, but now I'll ask him another question.
Yeah, ma'am.
Saurabh Mandliwar. So Anil, this is for you, okay? So again, your friend from Mumbai, Dr. Saurabh Mandliwar, he is asking, how good is use of smart masks used for children in ICMR program?
Ma'am, they are, I think they are, ICMR is doing a pilot study, ma'am. Actually, we all know diagnosing tuberculosis in children or pediatric population is very difficult, ma'am. So these smart masks, they are having a gelatin membrane over the mask, and we ask the pediatric population or pediatric children, I think children, to wear this mask. And after wearing this mask, we can collect this mask and subject to RT-PCR, ma'am. And whatever exhalation, actually we process the that particular mask via RT-PCR, ma'am. And whatever that pediatric children that he has exhaled over that mask during his exhalation, normal exhalation, ma'am, we can subject it to diagnosis, ma'am. And so we can pick up tuberculosis in pediatric population, ma'am. This is, I think, this is the pilot study, ma'am. The results, I think, I'm quite unaware of the results as of now.
Right. Okay, fine. This is again, I think, very well answered. I think it's good. This is again an interesting question. I think I'll give it to Dr. Animesh. I think because I finished everybody. Okay. So Dr. Animesh, there's an interesting question by Dr. Tridib that what about people who have fibrotic lesions on X-ray and they want to go to these Gulf countries and they don't get jobs? Do you have any suggestions to help them out?
I can't think of any at the moment, but...
Okay, so I'll tell what I do.
Yeah.
If I, yeah, sure. Tell us, Dr. Pradeep. Great.
Yes, it is a very common problem, madam, because people because Kerala people are more in Gulf. So at least we get at least 4 or 5 patients like that every month. It is like people working for 10 years or 12 years in the Gulf. Suddenly their government wants the screening, health screening, and they find some fibrotic scars. Then they will reject the visa and send back to India. They come to our TB center and ask what we can do. So it is very difficult situation actually. They are asymptomatic, they are incidentally fine. But anyway, we have to rule out active tuberculosis, and we do all the sputum examinations, CT scanning. And if there is no lesions, we usually give a certificate from the district TB center that patient is non-infective and non-contagious. And sometimes if there is no issues, they accept that certificate from the...
Oh, actually, no, in Gulf, it's never accepted because I know it. Because Gulf is somehow, they just feel that they don't want anybody with TB to come there.
Yeah.
And because a person with past history of TB has a chance of a relapse. So there is any kind of a scar, they just don't want to accept the patient, So
and there is a heavy penalty on the doctors actually if they provide the visa. So that is another thing they rejected,
Right.
Even if we give the fitness, I mean, if we say that serial city or whatever, shows a fibrotic scar, it is not active, they are going to reject it.
Right.
No, I think even Australia is very, very sensitive towards this. They don't want anybody to come with tuberculosis. They are very particular about it.
Correct. But I kind of feel that if we write it's old fibrotic lesion, patient has taken complete treatment, or there are calcified lesions in Australia, it's allowed. because a lot of students who I
Yes.
know who have given fitness, they've gone also. But Gulf is something where it's impossible to enter. So it's just
Okay.
bad luck, I feel, you know. So maybe there are
It's
still 4, 5 questions remaining, but we've already discussed them during our webinar and we've already gone over time. It's 9:40. We've been constantly talking since 1 hour 40 minutes. And you know, there's just so many new questions which we can keep on talking about till tomorrow morning. But I just want to say a huge big thank you to this fantastic, very, very accomplished panel. You know, I mean, each of you all have been an absolute star because you all have actually addressed questions and topics which have not been mentioned anywhere, and which all the knowledge that you all have given me is going to be so useful to me to answer questions that are put by my questions to me. Dr. Animesh, you've been absolutely fabulous, and I
Thank you.
really liked all the inputs from you. Radha, as always, wonderful answers and always adding your experience. Amazing. Dr. Pradeep Narayan, very good. You belong to one another world, you know, where all of you all treat TB just so well. And I just hope one day we try to match you and reach the level that you all have reached. Thank you so much for telling us about your experiences. Mahesh, thank you so much. You know, though you've gone to Calcutta, for us, you're very much our own. And we are very happy to know the way you think, the way you answer is still the way we do. So it's good that you continue to think the way we do. And I really like the answers given by you. Uh, Anil, thank you so very much. Quietly, you do all the work, and when you start talking, we come to know how much work you do. So it was absolutely wonderful listening to you. I really like listening to the smart mass thing that you spoke about. I think it was like a hotcake question which you answered very well. And Indu, thank you so much for, you know, all the time talking about incorporating private into public, private into government, and making sure our patients benefit the most, and bringing out a very important point that in this horribly contagious disease of TB, the psychosomatic part is something which is so important, which we really end up missing, which we should start addressing. So I think it's been a wonderful, enlightening webinar today, whereby all of us have learned how to prevent TB, how to prevent the patient's relatives from getting TB, how to prevent infection to become into active disease, the role of TPT, the role of BCG, the new vaccines coming up, the nutrition and the all the yojanas by the government, and so much more. So I think it's been a wonderful.
So, Dr. Amita, I'll interject. I think,
Yes,
I don't know if you have mentioned 1140 live logins Dr. Krishna had put up. So I
yes.
think we should
Yeah.
appreciate the audience also.
Oh, yes, a huge big thank you. Look, like, by the way, in the past, Dr. Radha mentioned 1140 logins, so I didn't say it, but I'm so happy you said it. So I'm very, very proud to say that all thanks to our fantastic faculty, we have 1140 logins, which is, I think, a huge, awesome number. And a big thank you to all our listeners for putting in so many questions and for logging in. So I think maybe we should close because it's been 1 hour 45 minutes.
And great moderation by you, Dr.
Yes.
Thank you.
Madam.
Yes.
I mean, you
You
have
have
covered
taken
all the
ahead,
questions. You have
Amita.
taken up all the audience's questions so very well, so encouraging. Dr. Rangarajan has asked so many questions and you brilliantly covered everything, you know. So I think great moderation as always, madam.
Thank you
And
so
kept
much.
it lively and kept it lively.
Kept it
Wonderful.
live.
Yes,
Thank
yes.
Thank you, ma'am. Thank you.
Kept the
Thank you, ma'am.
audience glued to
Yes.
the screen. Oh,
It was wonderful. One of the best webinars that I've moderated with the smartest faculty. I must say that every faculty, every panelist was extremely special, and all of you all have made very important points, which I think have helped me tremendously. And everybody, it's helped
So,
everybody
so
tremendously.
ending TB is everybody's responsibility.
Yes.
Just
If
to
everybody
conclude.
just wants to give a, I think, like, you know, every person can just give a take home message from you all. Each of you just say something to our audience.
So I just said, as it's a social disease, we have to socially eradicate also, you know, it's everybody's responsibility to kind of
Wonderful.
help each other in eliminating TB and, you know, help the government eliminate and achieve its goal.
Beautifully said. Dr. Animesh?
Awareness is the key. I always say that. I think awareness is the key. And you talked about stigma. I think we have to understand that this is something which we should not stigmatize.
Wonderful. Very, very good. Mahesh?
Ma'am, I just wanted to tell that, ma'am, when our webinar is going on, and I have received one screenshot from one of my lawyer friends and one of the doctor. So he mentioned that there is a provision to punish a patient if he doesn't follow the rules to contract the TB disease. So under the section 269, he can get imprisonment up to 6 months to 2 years with fine.
My God.
Great.
Okay.
Great.
I just hope they gave a individual cell to him in the prison.
Yes.
Very good. I'm so happy that this was told. Excellent. Wonderful. Okay. Thank you, Mahesh, for always enlightening us. Dr.
This was given by Dr. Ajay from
Dr. Ajay Lanjivar, I saw it actually.
Yes, yes.
Noted, but I wasn't sure. He said in Maharashtra this is the fine, but I wasn't sure, so I didn't want to really say it, So then, okay, Dr. Anil Maske, what would you like to say? Okay, till he comes back, Dr. Narayana Pradeep, what would you like to say?
Thank you, ma'am. Thank you, ma'am, for excellent moderation, ma'am.
Your message to audience.
Message to ma'am. I already told ma'am, nutrition is the best vaccine, ma'am. So I think that is the way forward, ma'am.
Wonderful.
So,
Dr.
yeah, ma'am.
Narayana Pradeep, what would you like to
Yes,
say?
it is. TB is not alone by doctors, madam. A lot of other people has to be involved, like local self-government, then other departments, social justice department, and field work is the key. We have to have that. Is the field staff is the major forefront runners in our TB programs.
Wonderful. Radha?
Yes. I think it's not only by these webinars, but other activities that we have. We all must come together, and then only we can reach to the goal of ending TB. It's a joint effort. We have to invest in the social cause also, as well as the clinical work that we have been doing has to be up to the mark for each TB patient that we come at.
Wonderful. All of you all have said very, very special points. And these are really, pearls of wisdom. And with this, I'd like to end our webinar. Again, a very, very big thank you to Dr. Krishna for thinking about this topic. And of course, to Dr. Vijay Chennam Chetty and also Dr. Atri and to Shivani for helping us all the time. So great. Long live time. And let TB die soon.
Yes.
Okay. Thank you. Good
Thank
night.
you. Good
Thank you
night.
for wonderful
Thank you and good night.
Thank you, Krishna.
Thank you, ma'am. Thank you, ma'am.
Thank you.